So thanks for the invite tonight. I think I was asked to come give a brief primer on what case mix adjustment is and how we use it. And this is something that you'll likely hear more about in the coming months. You may hear about it in a conference if you join us for the session, as PAC3 looks to do more risk adjustment in several of the outcomes that we look at. So hopefully we won't take all 20 minutes of the remaining time, but really, hopefully today I want to spend some time looking at defining what case mix adjustment is and describe when to use it and how to use it. Look at the benefits and the limitations of it. And then, I know it was brought up or the question came up, how does case mix adjustment play into many of the public reporting outcomes that we see, whether it's U.S. News and World Report or other organizations that report. And then briefly talk about how we plan to use case mix adjustment within the PAC3 ecosystem. And if at any time anyone has questions, feel free to stop me. It's totally fine. I put slides together just mostly to keep us on task and organized. So the root of this slide gets at the root of case mix adjustment. So how do we assess hospital performance? We're an organization that looks to raise the bar on quality and safety, and really fundamental to that is knowing how we're performing. So, there are several key outcome metrics that we look at, and what I have here is just a few. So obviously mortality, complication rate, readmission rate, length of stay. This list can go on and on. So for example, here I have looking at length of stay in the acute care cardiology. So we have two, let's for the sake of example, look at two centers, center A in blue and center B in green. So center A has a length of stay in the acute care unit of 2 days, total hospitalization in 4 days. So let's say these are post-surgical patients. Center B has 3 days and 5 days respectively. Now, at first blush, it looks like center A is doing a great job, right? So their length of stay is lower than center B. But how do we really know if center A is doing a good quote unquote job? Maybe it's because center B is taking care of more complex patients. They take on patients that require longer recovery times, and center A might have a lower case complexity. So both of these centers may very well be doing a good job. Maybe it's A, maybe it's B. We don't know because we don't really have an understanding of what the underlying patient population is. So the key of this is really to understand what that baseline population is. So we know that across the United States, if we look at all the different surgical centers, not all patient populations look the same or even remotely similar. You could even take an individual center, say I'm at Nationwide Children's Hospital, and the patient complexity, the mix of patients that we see, the types of patients that we see varies day to day, week to week, month to month, year to year. And the same can be held true across the country. So the patients that Nicholas is now going to be seeing down in Texas are different than what he was seeing in Cincinnati. So, and similar to us at Nationwide is different from those out at Stanford. So, we really have to recognize that not all patient populations look the same. And this is really important when we're looking at how we look at outcomes. So case mix adjustment, also termed risk adjustment, you may have heard that. It means the exact same thing. It's a statistical method or a statistical methodology to account for baseline population differences. So let's take, for instance, our population within PAC3. So we have, let's say, 20 centers that we're looking at outcomes for. So when we do a case mix adjustment, what we're asking, what the statement that you can actually make from this is what would Nationwide's, for instance, outcomes have been had our patient population been treated at a quote average hospital among the PAC3 collaborative. That's what it's really asking. So again, it's how would our patient population have done had they been taken care of at a average institution. And obviously the average institution doesn't exist, right? It's a statistical method. So it accounts for all of the variation across the cohort. So again, statistical method to account for baseline population differences. So what's the result of this? So oftentimes you'll see lots of different things out there, which can be confusing. But in general, when we look at case mix adjustment or risk adjustment modeling, the outcomes fall into one of three buckets. So you may have heard these terms. So better than expected, as expected, or worse than expected. So that means you're either performing better than your patient population would have done at an average hospital, or worse, or as expected. Now, what's been popularized across centers is the Society of Thoracic Surgery, or STS. Their nomenclature for this is the star rating. So you may have heard advertisements about a 3-star program or a 2-star program. And this is the exact same thing, just in number of stars versus words better than expected or worse than expected. And then similarly, you may see colors or other designations such as a high-performing center or an underperforming center. So typically we focus on the high performers when we're trying to identify centers that are doing a great job for their particular patient population. And we say they're either doing better than expected or they're a high-performing institution. So again, case mix adjustment allows for accounting for baseline differences in population among different centers and gives you a sense of an individual center's performance based on their patient population. Now, there are a couple of really important things to keep in mind here. So case mix adjustment or risk adjustment is it's a tool that can be primarily used for a hospital to evaluate their own performance. So when I look at, let's say, length of stay at Nationwide Children's Hospital, when I look at it and we look at better than expected or less than or worse than expected, that gives me a sense of whether or not that's an area of focus for us or an area of strength for us moving forward. And you can apply that across all the different outcomes that you perform risk adjustment for. You cannot, in all circumstances, it cannot be used to directly compare two hospitals to one another. So if I have, let's say that my center, Center A, is doing better than expected at whatever outcome you want to look at, say length of stay. And then we look at Center B somewhere else, and they're as expected. Does that mean my hospital is necessarily better? Not really. You can only make that comparison is if we have the exact same case mix, which is pretty difficult to have. So it's much harder. There are methods to mitigate some of that, and whether you do regional case mix adjustment or others, there are other tools that you can do to use that. But as it stands, for most case mix adjustments that you'll come across, whether it be in PAC3 or PC4 or STS, they're going to be, you can't really use them to compare two hospitals. So how does this get used in public reporting? And what I've highlighted here is many of the pitfalls that come with case mix adjustment. So there's a natural inclination that all humans have to make comparisons. So when you list out programs and you give some 3 stars and you give some 2 stars and you give some 1 stars, the natural inclination to anyone looking at that is that it's a ranking system comparing programs. But you got to be careful because the case mixes are all going to be different. So knowing what that case mix is really vital to interpreting those adjusted outcomes. So for example, a high-performing 3-star center might do 0 complex cases. And this is obviously an exaggeration, but just for the sake of example, or for the example, you could be a high-performing center who does all complex cases. You could be a high-performing center that does no complex cases. So if you're a family looking at what's reported in advertisements or in the U.S. News and World Report, it's really hard when you have a child that may have a complex heart disease looking at a center that may do 0 complex cases, but they're obviously considered a high performing or a 3-star center. And conversely, you may have a unique situation, or you may have a patient with a unique condition that is only taken care of at very highly specialized centers around the country. And without knowing that, the global risk adjustment is very difficult to interpret. So those are some pitfalls, but it's commonly used in public reporting. And I think the most commonly publicized is the U.S. News and World Report ranking and how it uses the STS adjusted mortality, or the AMR adjusted mortality rate. And we can go into more detail about that, but suffice to say that there can, for a lot of the reasons that I've brought up, it's very difficult to do a case mix adjustment on that type of outcome and let that suffice as public reporting. There's a lot more nuance to it, and a lot more that needs to go into making sure that patients and families and those that use these guides have a full understanding, or a better understanding, of what the statistics are behind these case mix adjustment and behind the rankings. So one of the things that, apparently the subscript should have been a superscript, but anyway, one of the things that case mix adjustment is really good at is, in our, let's say in PAC3, it's really good at identifying centers who do a good job. So let's say we look at length of stay, and we find that after we do our risk adjustment modeling, that Stanford does a fantastic job and Texas does a fantastic job. Well, as a cohort, we can identify those centers and say, okay, what are they doing that we can do, and we can spread that to other centers. That's really one of the powerful benefits of case mix adjustment. And it also allows individual hospitals to better understand their performance and say, okay, well, we're as expected in all of these metrics, and we're doing pretty good in these metrics, but there's 2 over here that we're underperforming at. And I think we need to spend some time focusing our resources and our quality improvement efforts at those to help raise the floor up for our patient population. So there's a ton of benefits, and I think both at the hospital level and at the collaborative level to do this. But again, the key is making sure that you have a good understanding of what the case mix is for a particular institution, and making sure you try to hold back on that natural inclination to do direct comparisons from one institution to another, because it's not quite that simple. As we look forward to doing our risk adjustments, we'll be able to use all sorts of different variables defining a patient population that we have, both within PAC3, PC4, STS, to help with our case mix adjustment models, similar to what PC4 has been successful with so far. So hopefully over the next couple of months, we will get rolling with this and have more to share in 2022 and beyond. Questions about risk adjustment from anyone? Yeah, and Elena's comment is very pertinent. So the transparency with how the models are developed is important, and not all public reporting websites have that transparent discussion about what goes into the case mix adjustment model. So for STS in particular, they do not keep that, or they keep that under wraps. So it's difficult to know what exactly they are using for their case mix adjustment, which, as you might imagine, leads to lots and lots of questions. So, and makes it hard to interpret what those mean. So, yes, I agree. And I think the other point to that too, and one of the challenges with things like STS is really not only different case mixes, but centers who perform very unique types of surgeries or interventions or take care of unique patient populations. So that is difficult from a statistical standpoint, it's difficult to model that as an average because it's a rare event, right? So those can fall into challenging parameters as well.
Stephen, I haven't ever dug into the risk adjustment models that PC4 has successfully deployed. Are they fairly transparent with at least the clinical leads with how it less of a black box like SCS? And do you foresee modeling after them or needing to like adapt and adopt?
Yeah, they actually do a really nice job. I have a variety of them printed out right here, but it would not show well on the camera. But you can actually see exactly what goes into their case mix adjustment models, or pretty close to what goes into it. They have a highlighted high level, so they may not show. I'm sure if you dig and ask, you can get it, but like what all the covariates are and or how they're weighted and all of that in the final models. But all the different elements that go into it are available on pac3quality.org or pc4quality.org. There you go. And this is something that, I think they've been very transparent with their modeling and what goes into it. I fully expect us to do a very similar situation. And whether that's, putting it on the website, which I imagine we will, PC4 actually, there are statistical tests to determine how valid the model is. So we can throw those up there too, and other such things. So I think we'll be good. Better than Willy Wonka.
Stephen, that was terrific. One thing to also just, I think, share in that when we look at statistical measures of a case mix adjustment model, anything that explains 75% of the difference is considered outstanding. And if you can explain 80% of the difference, that's considered like unbelievably a powerful model, which is terrific. But it also suggests that really at our very, very, very best, we can't explain 20% of the difference in performances between centers. There's lots of suspicion about what some of those elements might be that provide that sort of 20%. And it's the suspicion more and more is that it has a lot to do with the lives that people lead outside the hospital that we don't necessarily have good measures for. It won't come as a surprise, I think, to anyone in this discussion when we see lots of information about people's background and socioeconomic status and living environment and how that impacts their health. We don't have good models for that historically within pediatric cardiology, and it may explain upwards of 10 or 20 or 25% of the difference that we see in some of our outcomes. And as I think many of you know, PAC3 is going to work in earnest to shed some light, as much light as we can on that subject. But these models are really powerful and help us learn quite a bit and help us better understand our own outcomes and our data and get better and better and better. But at the same time, I think we have to acknowledge that even at their very, very best, 20% of the difference is unexplained. And that's obviously still very significant.